Hello guys, so this is the pathology installment of the West African College of Surgeons revision questions for primary, as I promised in my last video on the same subject. Basically, these questions are very easily accessible around, but the reason I've taken it upon myself to put down this high yield collection together is because if you have the answers as I mentioned earlier, and you just have only answers without explanations, it will not be a good revision point. However, you could have the questions without even having the answers, which is worse. So in this revision series, I try to compile high-yield revision questions, give you explanations to them, and where it is necessary, I try to give explanation to surrounding options in the answer. So without wasting time, let's just dive right into it. Pathology revision questions for Wacs. Question number 1. A teenage boy has episodes of swelling of the upper lip and abdominal pain. There is a family history of angioneurotic edema. The defect underlying the episode is. Now, I'll just take this step by step. Abnormal sensitivity to histamine leads to what is called histamine intolerance, and mainly you see it in people with inflammatory bowel disease or irritable bowel syndrome, so this kind of thing. Then deficiency of a C1 esterase inhibitor is actually our answer, so I'll highlight it and then try to explain how it works. Alright, so this is our answer. Now, C1 esterase is the enzyme or the protease, the protein that activates the complement system in such a way that if it is working or overactive, you have more production of the downline product of the complement system. And that also includes, apart from the complement system, activation of prekallikrein, which is needed in production of bradleykining eventually. Bradleykining increases vascular leakage, sort of, so that will make a fluid to leak outside the vessels into the interstitium and cause edema. Now, C1 esterase inhibitor is more like a regulatory protein that keeps all of these activities in bay. And when it is deficient, you will realize that you're going to have more of the product of the complement system, and of course, you have more of bradleykining. This is what actually leads to hereditary angioneurotic edema. All right. So the last option here, which is membrane damage by C56789. That's an attempt to actually represent the membrane attack complex, one of the final products of the complement system that eventually damages the membrane. Okay, so question number 2, foreign body giant cells are derived from. Okay, so giant cells, you can broadly divide them into physiological and pathological giant cells. The ready example of physiological giant cell would be the osteoclast that is required in bone function. But then I think the important thing to know here is about the pathological giant cells. You have foreign body giant cells, you have a Langhans giant cells, and then you have this Thornton giant cells. I think I should probably write this down. Okay, let's see. Yeah, so there is foreign body. This is me classifying a pathological giant cell, and then there is Langhans, okay, and then there is Thornton, okay. Can put in a Ristenberg giant cell. Okay, now these are all types of giant cells. There could be more, really. These things are many. Foreign body giant cells is what you see if you have giant cells forming as a result of, let's say, suture remnants, okay, after repairing a tissue. Langhans giant cells are associated with granulomatous disease, so things like TB will give you Langhans giant cells. This is suture, okay. Then Thornton giant cell, what you likely see in fat necrosis. All right, fat necrosis. Now, what is important to know is that of all these giant cells, all of them except Ristenberg giant cells are formed from macrophages. Okay, so if you remember that, you can easily answer this question. All right, so foreign body giant cells are derived from. The answer is pretty obvious now. macrophages. Question number 3. Metastatic classification is seen in. Okay, so I'll try again to define this. Metastatic classification, when you have calcification occurring outside bones, or where there's supposed to be calcification, it can be as a result of metastatic calcification or as a result of dystrophic calcification. So metastatic calcification is due to hypercalcemia. Okay, due to hypercalcemia. That's metastatic. So you see that in hyperparathyroidism, obviously, where there's increase in the amount of calcium, serum calcium ionized mainly, and then it begins to deposit in normal tissues. So you have hypercalcemia. All right, hypercalcium. All right, but then dystrophic calcification does not need hypercalcemia to occur. So basically, there is calcium deposit in abnormal tissue, and you see this in mainly, say, in malignancy, for example. And the malignancy, you mainly see them as things that any malignancy like papillary in nature is likely going to present with dystrophic calcification. So you have papillary thyroid carcinoma, it will present with that. If it is papillary cyst adenocarcinoma, ovarian tumors that are papillary, anyway, they have papillary tumors, including a papillary renal cell carcinoma, will likely give you a dystrophic calcification. But then there are just some few examples where you have them and they are not necessarily papillary in nomenclature. Example is meningioma, then glucagonoma, prolactinoma. So just those three should be fine enough. Okay, so if we're going with that, then our answer is obvious that metastatic calcification here will be caused by hyperparathyroidism. Question number 4. Factors that retard the healing of wound include all the following except infection, of course, retards wound healing. UV lights shouldn't, because if anything, but let's eliminate other options and then we'll see that should be our option. Lack of immobilization means that if it's a place that requires the tissues to be together, the edges to be opposed, and you don't immobilize, chances are that the movement will stop the reunion of the tissues. Okay, diabetes mellitus, hyperglycemia, of course, will impair wound healing. Exogenous steroids steroidally impair wound healing. So we are left with UV light, which is our correct answer. If anything, if we are going to think about vitamin D, we realize that UV light should actually encourage wound healing because vitamin D is also necessary in wound healing. Question number 5. Macrophages secrete all the following except, okay, so interleukin-1, macrophages secrete a lot of inflammatory mediators. So let's see. Interleukin-1 is an inflammatory mediator, TNF also, arachidonic acid derivatives also, plasminogen activator. But then you see number E, kappa chains of immunoglobulin. The immunoglobulins we have, our antibodies, have heavy chain and then light chain. Okay, so the heavy chain determine the name we call them. So it is from the heavy chain that you get things like immunoglobulin G or mu, that's M now, or D or E, okay, or alpha A. All right, but then for the light chain you have just kappa or lambda. All right, there's a way to draw the Greek letters. I can't draw that now. All right, so these are all components of immunoglobulin. Immunoglobulins are secreted by plasma cells, so definitely not macrophages secreting them. Yeah, maybe worth mentioning, I don't know how necessary that will be, is that the chromosome level that determines the kappa chain is at the second, and then the L or lambda is at the 22nd chromosome point. All right. So question number 6. All the following conditions represent a type 2 hypersensitivity reaction. What we probably need to do first here is to think about each type of hypersensitivity reaction. So type 1 is immediate, So usually you're looking at histamine release and the rest of them. Type 2 is antibody mediated. Okay. Type 3 is immune complex. Antibody antigen complex. Immune complex that should be deposited as sites, usually like things like vasculitis. Type 4 is cell mediated, or call it delayed. Alright. So let's see. All the following are conditions representing type 2 hypersensitivity reaction except A. Autoimmune hemolytic anemia. Okay. Myasthenia gravis. Autoimmune hemolytic anemia is due to antibodies, and that's why you can detect them with Combs test, direct or indirect. Myasthenia gravis antibodies are formed against acetylcholine receptors and neuromuscular junction. Transfusion reactions due to preformed antibodies, ABO incompatibility. Graves' disease, still same antibodies are formed. The difference is that instead of the antibody destroying the receptors, they actually end up stimulating the receptors, causing a sort of hyperthyroidism. And then hay fever is typical of immediate. Alright, so that should be our answer. That's the except there. It is not antibody mediated as it were. It's immediate, and mast cell degranulation is the main thing involved. Question number 7. Immune complex mediated, that's type 3 now. Reaction causes tissue lesion in. So they are basically asking us, I mentioned vasculitis already as one of the typical ways that you can represent type 3 hypersensitivity reaction or immune complex mediated reaction. So I think we could just look for one here. Polyarthritis nodosa is a form of vasculitis. That is our answer, but let's look at the others. Pemphigus vulgaris, bullous pemphigoid. Poison ivy should be type 1. Then chronic renal graft rejection is what could have confused us, but then there are many factors or mechanisms involved in chronic renal graft rejection. So there's both immune and non-immune path to it, including things like intimal hyperplasia, thickening of the vessels, and the rest. So vasculitis, in the presence of vasculitis, we are not supposed to actually be guessing another answer, and that will be our answer, polyarthritis nodosa. Hydropic degeneration of the renal tubular epithelium occurs in. Okay, so hydropic degeneration basically is like the cell swelling because of accumulation of water. So you will expect to see that if let's say the sodium potassium ATPase pump is not working, because that's supposed to regulate membrane integrity in a way. So now, chronic alcoholism, excess renal sodium loss shouldn't give us that. Hypokalemia shouldn't give us that. The two options that make sense here to consider are mercury poisoning and carbon tetrachloride poisoning. However, mercury poisoning, when you hear that, you should think more about neurological symptoms, okay, behavioral symptoms. Then carbon tetrachloride poisoning, you expose the kidney cells to oxidative stress. This oxidative stress is more likely to damage the membrane integrity by interfering with the sodium potassium pump, and that will lead to the cell swelling up, and that's hydropic change that they're talking about. So I will take that. Alright. Question number 9. The lipid in hepatic cells in fatty degeneration is mainly in the form of. Okay, so fatty degeneration in the liver, that's fatty liver disease. The accumulating lipid is actually triglyceride. Okay, and this is in contrast to the lipids that will accumulate if you're having an atherosclerosis, atheroma, okay, or xanthomas, where you're expecting cholesterol and cholesterol esters. All right, so it's important we distinguish that. Yeah, so triglycerides, that is fatty liver disease, and you should distinguish it from atherosclerosis, where you have cholesterol and cholesterol esters accumulating mainly. Urethral obstruction of long standing due to prostatic enlargement leads to which of the following changes in the urinary bladder muscles? Okay, so if there's obstruction of the ureter, obstruction of bladder outflow, it means the detrusor muscles have to work extra. when any muscle works extra, basically they hypertrophy. So what happens that we should note about the bladder muscles is that as they are hypertrophying, it gets to a point that they now form out pockets. Okay, they form out pockets. So from being like this, they can become like this. All right, they form out pockets. Forgive the diagram, but then I think you get the point. So they form out pockets, and when they form these out pockets, the out pocketings are called, or the out parts, the out pockets are called diverticular, and then what is left, the elevated mucosa inside, is what you call trabecular. So diverticular and trabecular formation is one of the pathological changes you expect in chronic urinary outflow obstruction, like in BPH or CAP. All right, so let's go. Question number 11. In a patient with chronic right ventricular failure, the usual pathological changes which occur in the liver is chronic right ventricular failure means that there will definitely be impairment of venous return, and that means there will be backflow of blood to the liver, so you expect that the liver will be congested. So this is what is referred to as Nutmeg Liver. Okay, this is what is referred to as Nutmeg Liver. So it is hepatic congestion. It's called congestive hepatopathy too. Yes, hepatic congestion due to right ventricular failure. And if it is long-standing, the liver thickens and you have what we call Nutmeg Liver, which is also called cardiac cirrhosis. Cardiac cirrhosis. This is when I saw this as a medical student in a scan. I remember thinking that whoever did the scan didn't know what he was doing. One of the humbling experiences of medical school, because you realize that in medicine some things that sound way odd actually happen. All I knew then probably was liver cirrhosis as it were. So I thought, is it a mistake? How can you have cardiac cirrhosis? But yeah, Nutmeg Liver, cardiac cirrhosis, congestive hepatopathy, they're all the same. And that is congestion of the liver due to backflow or impaired venous return in right ventricular failure. Question number 12. The basic causes of edema include all the following except. So the forces that are playing at the capillary level, pre-capillary and post-capillary level to affect fluid exudation or retention within the intravascular space. We include both hydrostatic and oncotic pressure. The hydrostatic pressure within the vessel, of course, will tend to push fluid out. So things like the increased capillary blood pressure will want to push fluid out. Okay, so this is going to be in favor of edema formation. Increased permeability of capillaries and venues will also mean in favor of edema formation. Then there is increased plasma oncotic pressure. For example, you have more plasma proteins. So this will keep fluid within the intravascular space. So it is definitely not going to increase your chance of having edema. Obstruction of lymph flow will increase chance of having edema because there will be backflow from the lymphatics into the interstitium. Then sodium retention will eventually, because of increased intravascular volume, increase hydrostatic pressure inside the vessel, and that will favor fluid exudation. So our answer definitely then is the exception, which is increased plasma osmotic pressure. It will keep fluid within the intravascular space. Squamous metaplasia occurs typically in which of the following? Bronchi of chronic smokers. This should be straightforward in the sense that in the respiratory tract you have the respiratory epithelium, which is a pseudostratified ciliated columnar epithelium. In chronic smokers, this can transform to squamous cells, so that would be squamous metaplasia. Skin exposed to sunlight can undergo a lot of dysplastic change. However, the skin already has squamous epithelium, so even though it's going to still be dysplastic, but squamous is not actually a metaplasia. Then a callus is just new formed bone. Barrett esophagus, the squamous esophageal mucosa turned to intestinal columnar cells. Okay, so that is actually columnar metaplasia. Then chronic gastritis does not lead to squamous metaplasia. So we're left with option A. So our answer. Question 14. Causes of increased tendency to thrombosis include all the following except aspirin is antiplatelet, so it will prevent thrombus formation. Atherosclerosis will definitely increase increase blood viscosity. Atherosclerosis will increase tendency to actually form thrombus. Increased blood viscosity should also increase it. Pancreatic carcinoma, malignancies will increase tendency to form a thrombus. Use of intravenous catheter, foreign body, just think of it that way. You're likely to increase chance of forming a thrombus. So the only exception here is actually the use of aspirin. It will not increase the chances of forming a thrombus. Question number 15. When a left ventricular mural thrombus develops, infarction may result in all of the following except. So left ventricular mural thrombus will be propagated into the systemic circulation. So the question they're asking us is which of these will not be supplied significant blood from the system. So we're looking actually for the lungs then, and that's it there. So because the lungs will be supplied from the right heart, the minimal blood supply from the bronchial vessels through the systemic circulation will not necessarily give infarction. Rather, the infarction is more likely to occur if there is a blockage of a pulmonary artery supply, and then the little blood supply coming from the bronchial vessels will make the infarction to be hemorrhagic or a red infarct. Question number 16. The impaction of a coagulum of blood in a vessel at the point beyond which it cannot pass is called, I think this is straightforward, I won't waste time on it. That's an embolism. So it's whether it is even blood or any substance at all that dislodges and then goes to impact at an end point along the vessel tract flow that it cannot pass, maybe because of size. We say that's embolism. It can be air, it can be blood, it can be clot, it can be anything really. Hemorrhagic infarction characteristically occurs in, I think I've explained this already, why it has to occur in the lungs. Another place you can find that is in the intestine because of course portal versus systemic venous supply. Alright. Question number 18. The process by which inflammatory cells are positively attracted to a focus of tissue is, of course, this is chemotaxis. I will also not waste time on this. Chemotaxis, chemoattraction. Question 19. The digestion of foreign material by a neutrophil or macrophage during phagocytosis is mainly due to, okay, so this is important. This is digestion, not killing. Okay, there is oxygen-dependent killing that they have to do using the hydrogen peroxide or NADPH-dependent oxidase or so. But then the digestion of phagocytosed material, the digestion of phagocytosed material is mainly by lysosomal enzyme. All right. So I think there's a question that will lead us to talking about the oxygen-dependent killing later. Question number 20. A major cause of pain in foci of acute inflammation is Bradleykining. This is what stimulates pain nerve endings and elicits the sensation of pain. Complement, of course, not. Histamine causes vasodilation, but it doesn't stimulate nerve endings. Hydrogen peroxide doesn't, neither does superoxide do that. Question number 21. Granulomatous inflammation is a characteristic of all of the following except berylosis, yes. Foreign body reaction, we already talked about that. Fungus infection, fungi should give you that. Leprosy, yes. But you see pertussis caused by Bordetella species or Bordetella pertussis. Let's see if I can spell that. Bradleykining, okay. This is actually a bacterial infection, and what's the common name now? Whooping cough, okay. So you expect more of acute inflammatory kind of reaction and not a granulomatous reaction. So that will be our answer. Purchases. Alright. A 1-year-old boy had frequent infection due to Staphylococcus aureus. NADPH oxidase activity in his neutrophil was absent, so hydrogen peroxide was not formed. The most likely diagnosis, this is the question I was talking about. When people have a deficiency of NADPH oxidase, they suffer from a disease known as chronic granulomatous disease. Okay, chronic granulomatous disease. The exam I wrote, this question was I want to say reverse engineered. So, but yeah, it was actually reversed, but the answer is still here. So the question was now, people who have NADPH oxidase deficiency suffer from a disease called chronic granulomatous disease. Which of the following organisms are they most susceptible to? Wow, English is hard. Are they most susceptible to? So yes, they listed many options, and Staph aureus is one of them. So you should take note of that, because they list many common organisms, Staphylococcus aureus, then you have strep pneumonia and all other kind of common organisms. So this is important. Chidiac-Higashi syndrome, what you see when there's mutation in lysosome trafficking regulator. The gene is list here. I think that's it. List. Then for Job syndrome is another name for hyper IgE syndrome, hyper IgE, immunoglobulin E. So it's both stimulatory and inhibitory to the immune system. Then for lazy leukocyte syndrome, basically it's like a leukocyte that does not respond to proper chemotaxis. So the chemotactic factors are there, but the leukocyte is not able to migrate fast enough or at all. And usually because motility disorder is because of maybe the microtubules that are supposed to deform and allow the cells to actually move towards the chemoattractant. So it's motility disorder of neutrophil. Okay. Yeah. Of course, myeloperoxidase deficiency is myeloperoxidase deficiency, not NADPH oxidase deficiency. Question 23. The phenomenon which most definitely indicates that a neoplasm is malignant is also an easy question, so I won't waste time on it. If anything can happen to a cancer cell, and you might still be in doubt whether it's malignant or not, but once it metastasizes, it is malignant. So yeah, let's highlight that. Metastasis. Okay, if it is a surface tumor, and then you will be looking at the invasion of the basement membrane, sort of, which is more of local metastasis. Question 24. All the following chemicals are carcinogens except asbestos is incriminated in mesothelioma. Okay, so aspartame is more or less a sweetener, and there's no research or document that actually has implicated it for any cancer like that. Benzpyrene is all these aromatic hydrocarbons, and of course, when you hear aromatic hydrocarbons, you think about bladder cancers. Methylcolantrine is actually the laboratory chemical they use in experimental cancer research to induce mutation. Then vinyl chloride, polyvinyl chloride is implicated in angiosarcoma. Okay, I think I should probably write all of those down. Okay, so angiosarcoma, hepatic really. So it's liver cancer, but hepatic angiosarcoma. Then benzpyrene, you think of bladder C, aromatic hydrocarbon. Aspartame, and no definite association. Even if there's an association, it will be the least to be considered here, so that will still be your answer, because the rest have known association mesothelioma. Yep. Okay. Question number 25. All of the following are characteristically found in cases of Oncogenosis, except Oncogenosis is more like how do you put it? Okay, so there's deposition of a homogenesic acid, and it leads to discoloration. Usually, discoloration most times of tissues can be cartilages or even skin. But then the Oncogenosis can be exogenous or endogenous. Exogenous from things that will take around, some kind of foods or chemicals, alright? But then the endogenous can be due to a mutation involving homogenous oxidase, which is the enzyme that is supposed to actually convert a homogenous acid. So if that is deficient, you realize that you're going to have accumulation of homogenous acid, and the accumulation of homogenous acid is what we refer to as a captonuria if it is due to deficiency of homogenous oxidase, and that is the endogenous Oncogenosis. Now, the accumulation can affect joints, so arthritis is definitely there. Deposition of melanin-like pigment, that is what it looks like when it's deposited on skin or any other tissue. But the skin is not photosensitive, even though you have these depositions. Then, recessively transmitted inheritance. Yes, captonuria is a recessive disorder, so you have to get the two defects, the two genes defective from both parents to actually have it. So photosensitivity will be our exception in this option. Photosensitivity, so I'll basically highlight that. Then we'll move on. That's all right. Okay, so I think I will draw it if it's not highlighting. Yeah, exactly. That's our answer. Alright. So question number 26. All of the following are features of fetal alcohol syndrome, except when you hear of fetal alcohol syndrome, you think of three things. One is this morphology of the head and the face, and that includes both the brain and any structure in the face can actually be deformed. And then you think about cardiac abnormalities, and then you think about genital urinary abnormalities. So with that, let's see if we can answer the question. Abnormal low body weight, more or less anything that leads to this morphogenesis can lead to this. But alcohol can lead to placenta insufficiency and lead to this. Hirsutism, nothing of the things I've mentioned should lead you to that. Interventricular septal defect can fall under cardiovascular abnormalities. Mental deficiency can fall under head and face dysmorphology because you have a microcephaly. Then microphthalmos can also fall under the same. So our answer here will be tending towards drawing towards hirsutism. Okay. Question number 27. A diabetic patient developed a carbuncle. Aspirated pus grew out Staphylococcus aureus. Hematogenous complication of such staphylococcal infection includes all of the following. So they're asking you what blood spread of Staph aureus can cause. Endocarditis, definitely. Hepatitis is mainly viral, and we have established viral organisms A, B, C, D, E. Okay, lung abscess, of course, osteomyelitis, of course, and pyelonephritis, of course. So we're taking this. Question number 28. Ulcers of the ileum over enlarged Peyer's patches are classically finding. If there's ileal ulcers, you will think about, if you're thinking about infective causes, you think about typhoid ulcers, typhoid perforations. If you're thinking about non-infective causes, you think about things like Crohn's disease. So we'll look for any of that here. Yeah, so we have typhoid fever, so we'll just pick that. Typhoid fever. All right. Question number 29. The finding of caseating granuloma in a tissue section is basically diagnosis of TB, tuberculosis. So I think this is also an easy question that we shouldn't waste time on. But remember, as I said, granulomatosis including TB have Langerhans giant cells. So in the center of this granuloma, you have caseous necrosis in TB. In acquired immunodeficiency syndrome, the immune defect is due to depletion of CD4. So this is also an easy question because we already know that aside doing the HIV RNA viral load, another way that this is prognosticated or followed up is CD4 count, and that's because the HIV virus uses the CD4 cell DNA to actually replicate. So eventually it will deplete the body of CD4 counts, CD4 cells. Okay, so A is our option. Question number 31. Okay. Question number 31. Alright, let's see. The underlying cause of kwashiorkor is kwashiorkor is one of the protein energy malnutrition, and there are many classifications to it. So, but then the clinical classification will give you kwashiorkor, marasmus, then marasmic kwashiorkor. Then there are many other ones and types on that depending on what you're using, especially in pediatrics, using Waterloo, Gomez, and the rest of them. So in kwashiorkor, you have deficiency of protein. In marasmus, you have deficiency of both carbohydrate and protein. Okay, so we're looking for low protein here or deficiency of protein. High protein diet, no. Low calorie diet, no. Low fat, low protein, that is our answer. Alright. The 3-year-old man presents with a 5-week history of calf pain and swelling and low-grade fever. Serum levels of creatinine kinase are elevated. The muscle biopsy reveals numerous eosinophils. Wow. What is the most likely etiology of this patient's myalgia? Alright, so this question, the strong points are, okay, calf pain. So we believe that this could be affecting the calf muscle, and swelling. Then this patient has fever, so likely infective or immunological. Then there's creatinine kinase that is elevated, so pointing us back to muscle. And the biopsy reveals eosinophils, which you see in parasitic diseases. So this patient likely has, I think I have to type that down to pronounce it. Okay, trichinosis. Okay, some people, it can also be called trichinellosis, yes. And it's a parasitic infection, of course. So that is what can give us all of this. And you get it from eating a poorly cooked meat. It can be pork, dog meat, or any meat really that is around that area. So yeah, autoimmune disease is not our answer. Bacterial infection is not our answer. And muscular dystrophy is definitely not our answer from what I've pointed out. So parasitic infection is what can explain all of this. An 80-year-old man complains of lower abdominal pain, increasing weakness and fatigue. He has lost 7.3 kg in the last 6 months. The prostate-specific antigen test is elevated at 8.5. We expect normal to be less than 4, but then it is of course according to age. Rectal examination reveals an enlarged and nodular prostate. A needle biopsy of the prostate discloses invasive prostatic adenocarcinoma. Histological grading of this patient's carcinoma is based primarily on which of the following criteria. So the simple question is, prostate cancer grading is based on what criteria? The criteria you use or the grading system used is the Gleason score. Okay, let's see. Yeah, that should be, I hope that's it, Gleason score. And basically it takes 2 scores, and those 2 scores are the most prevalent histological types, and the histological types are according to how far or near they are to the original prostate tissue. So that will be resemblance to normal tissue of origin. Yeah. Question number 34. A 23-year-old man with hemophilia. So this man definitely bleeds easily. He's recently wheelchair bound. Wheelchair bound means he can't walk. So which of the following best accounts for this? What will make a patient that bleeds easily not to walk? Definitely blood has been has extravasated into the knee joints or any of the lower limb joints, but most especially it will be the knee joints. And what is this called? That is hematemesis, of course. Hematemesis is vomiting of blood. Hematocephalus will be blood in the brain or ventricles, but it rarely said that way anyway. Hematochezia, bright red blood, so that's bleeding per rectum. Hemoptysis is coughing out blood, different from hematemesis. A 40-year-old malnourished woman present with 6-month history of night blindness. Physical examination reveals keratomalacia and corneal ulceration. Which of the following vitamin deficiencies would be suspected in this patient? Which vitamin deficiency causes night blindness? This is straightforward and I won't waste time on it. So that's vitamin A. Alright. Retinol. A 65-year-old man undergoes cardiac bypass surgery and is placed on post-operative broad-spectrum antibiotic prophylaxis. Several days later, he develops fever, abdominal pain, and bloody diarrhea. Colonoscopy biopsy demonstrates a thick mucopurulent exudate. Which of the following is the most likely etiology of this patient gastrointestinal disorder? And the important thing here is that this patient underwent a major surgery, okay, after which he is placed on broad-spectrum antibiotics, and then of course several days later the patient develops what? Fever, abdominal pain, that's important too, and bloody diarrhea. So something definitely wrong with the GI, and there's colonoscopy biopsy that shows mucopurulent exudate. And they're asking us what is the etiology. This patient has typically the history of someone that has pseudomembranous colitis, alright, because broad-spectrum antibiotics will predispose to that. And what we colonize the GI and the background of broad-spectrum antibiotic use is Clostridium difficile, which is the causative organism for pseudomembranous colitis. And then you treat this by giving vancomycin or metronidazole. So yeah, that's our answer. 37. A 5-year-old boy is brought to the emergency room with a fever of 38.7, chest pain, and productive cough. The patient has chest pain, has fever, he has cough. The patient has a history of recurrent pulmonary disease, recurrent pulmonary and respiratory distress. What microorganism recovered from the lung of this child is virtually diagnosed with cystic fibrosis? When you hear cystic fibrosis, and we're talking about an organism that can cause recurrent respiratory infection. Recurrent because it is difficult to eradicate. You think of what? Pseudomonas species. And the reason is because it has a mechanism via which it implements antibiotic resistance, and that is formation of biofilm. Alright, so not that deep, but I have to type it, biofilm. So this makes it resistant or makes it difficult for antibiotics to get to it. That's Pseudomonas for you in the background of cystic fibrosis. So it coats itself up. 55-year-old female develops left ventricular heart failure and pulmonary congestion. If the congestion becomes chronic, it may eventually lead to which of the following pulmonary complications. So the question here is trying to test our knowledge of what would happen if there's recurrent backflow of blood towards the pulmonary system. So what you realize, of course, you expect that there will be pulmonary hypertension. Eventually the vessels and the interstitium should thicken. That's what you should expect because of the recurrent congestion. So alveolar pneumothorax hyperplasia, not likely. Gangrenous necrosis, not likely. Granulomatous inflammation, no. So this is thickening or fibrosis of the of the interstitium, and that works for us. Malignant neoplasia, this should not cause it. Congestion should not cause that. Of the following listed below, the most common cause of delayed wound healing is. The most common cause of delayed wound healing is infection. Everything here probably can cause a delayed wound healing, but infection is the commoner one. Yeah. Question 40. The most common underlying cause of fat emboli syndrome is fat embolus or emboli syndrome is more encountered in orthopedics. And the reason is because of fracture. That's what they are managing most times. So long bone fracture is a commoner cause of fat embolus. So many other things can cause it, but that's distant. You hear of fat embolism, think long bone fracture. If the patient has long bone fracture and starts developing respiratory distress, you think of fat embolism first. Alright. There. Question number 41. An 8-year-old boy develops a sore throat, fever, and a clear nasal discharge indicative of common cold. So they've made us know that what this child has is common cold. In the inflammatory infiltrate within the submucosal tissue of the nasopharynx, you would expect to find the predominance of what cells, okay? So now, this question is testing your knowledge of which cells predominate depending on the causative organism. And if they've told us it's common cold, we know that common colds are viral in origin and self-limiting. So we're looking for which one has lymphocytes. So yeah, so that's lymphocytes. Mast cells will be for allergy, neutrophils will be for acute bacterial inflammation. Eosinophils, you see that parasitic, and then plasma cells are plasma cells secrete antibodies. Alright, question number 42. Of the following, the earliest step in formation of thrombus is usually when it is time to form a thrombus or to initiate blood clotting. Usually the first thing that happens is endothelial injury, because the endothelial injury is what will expose the subendothelial collagen that will attract and lead to platelet attachment, and that will also activate the clotting cascade via the contact factor or Hedgeman factor or factor 12. Okay, so yeah, we're looking for endothelial injury, and that's it right here. That's the first step. Question 43. Most infarcts of the kidney are ultimately replaced by. Now, infarcts, solid infarcts generally, or white infarct, or infarct in solid organs, are usually replaced by scar tissues. Okay, so most infarcts are actually still white infarcts, except that happens in the lung, as we've talked about. So the most infarcts of the kidney are ultimately replaced by scar tissue. Same thing with the heart, which is why things like myocardial infarction are also very dangerous. So because the muscles will not regenerate. These are not labile cells. Alright. Of the following cell types, the first which aggregate at the site of acute tissue injury are neutrophils are the first to run down, and although they are the first to run down and initiate action, they also have a very short half-life. So within hours they are gone, so that by the following day other cell types predominate. Question number 45. Which of the following is most likely to have grossly identifiable lines of Zahn? Now, lines of Zahn are alternating lines of you have a red area filled with red blood cells, and then you have a paler area filled with what? Platelets and some fibrin. And you see this kind of thrombus if they are formed within the heart or in the aorta, so that's more of an arterial thing. So that is what we're looking for, arterial thrombus. So capillary, extravascular, hematoma, postmortem, and venous will not be our answer. Which of the following statement best defines the term labile cells? I think I just used that word, labile cells. They are continuously in they are cells in a continuous cycle of cell division. Yes, that should be our answer. So they don't stop, they keep dividing. And then you have stable cells which are not constantly dividing, but then they will be able to enter into regeneration if they are injured or if the stimulus is right. Okay, but then you now have permanent cells which will not go anywhere no matter what you do to them. They just basically die, turn into fibrous tissues. Question number 47. What are heart failure cells histologically seen in pulmonary edema? Heart failure cells are macrophages that have engulfed red blood cells, and these red blood cells are extravasate into the interstitium. They are engulfed by macrophages and then digested. So then the iron in the red blood cells are stored as hemosiderin in this macrophage. So you have hemosiderin-laden macrophages, and call them siderophages. Okay, it's not only peculiar to heart failure, but here that is what is important to us. Psammoma bodies are seen in which neoplasm? This question, because of a question I've answered already, becomes simple in the sense that psammoma bodies are actually just dystrophic calcification in tissues. So I mentioned that apart from papillary neoplasm, whether a papillary thyroid carcinoma, papillary cystadenal carcinoma, papillary mucinous carcinoma, papillary renal cell carcinoma, you will see psammoma bodies in them. But there are non-papillary lesions. They are non-papillary nomenclature, but you see psammoma bodies in them. And the example will include meningioma, you have glucanoma, you have a prolactinoma. So psammoma bodies are seen in meningioma. That will be your answer. What is the most common pleural tumor? Okay, the most common pleural tumor is actually mesothelioma. Excuse me. And the thing with mesothelioma is that mesothelioma is malignant. It doesn't matter whether they put malignant mesothelioma or not. Okay, so it's malignant, it's always malignant, and prognosis is not so great. It takes years to develop, like 30 years or so, 15 to 30 years I think, to develop. But then once it develops, it is malignant, and prognosis is not that great. Question number 50. During repair, which of the following substance is essential for pro-collagen fibers to transform into collagen fibers? Okay, so I will remember hydroxyprolination, which needs vitamin C, so that's what we're looking for. And we have cortisone now. Carotene, ascorbic acid is what we can take here as our vitamin C. So this is the summary or the last question I'm taking on this pathology review. And as I said, the reason I compiled these questions is not because you can't find them easily around, but one is that sometimes you don't see the answers, and that becomes a problem. Having to source for the answers all by yourself will take you a lot of time. And two is that even if you find ones that are answered, you just have number one is A, number two is B, which I don't think will contribute to your revision. But with what we've done, you are able to know a little around them and a little extra about each option where possible. So I hope this has helped you. And if you have questions, you can drop them in the comment box. Or if you think that there are some errors in the knowledge I've shared, you can also just put in the correction in the comment box. And if you have not subscribed, it will do me a great good if you just hit the subscribe button now and subscribe to my channel. You can put on notification because subsequently I'll be sharing more videos that I believe will be beneficial to you. Thank you and have a good one.